In the continuation of infectious medicine, today the topic is malaria. So malaria is caused by a very well-known parasite that is called as Plasmodium. So it is caused by Plasmodium. Plasmodium is transmitted by female anophles mosquito. So female anophles mosquito is considered as a vector for the Plasmodium. Now what are the different species of Plasmodium? The different species of Plasmodium are, that is Plasmodium vivax, Plasmodium malaria, Plasmodium ovale, Plasmodium falciparum, and Plasmodium knowlessi. So these are the different species for the Plasmodium. While Plasmodium vivax and Plasmodium ovale, it is considered as a most common species for the Plasmodium, while Plasmodium falciparum is considered as a most dangerous species for the Plasmodium. So whenever female anophles mosquito bite a healthy person, so what happens? So female anophles mosquito carrying Plasmodium will bite a human, a healthy. So what happens? It injects the sporozoites. It injects the sporozoites in blood of healthy person. These sporozoites travel up to liver and hepatocytes. It forms the schizoid. It forms the schizoid. So within schizoid, these schizoid, then it get replicated within the liver. These schizoid replicated, so these schizoid replicated within the liver and it forms the merozoites. Now these merozoites, it release from liver, and spread in the blood and infect the human RBC. So when it infect the human RBC, how it infect the human RBC? That these merozoites within the RBC, it proliferated again and again. It proliferated again and again in such a way that it destroyed the RBC. Once RBC destroy, so it lead to what? It lead to hemolysis. So I repeat, the female anopheles mosquito bite the healthy person and inject the sporozoites in the blood of healthy person. These sporozoites it travel all the way to the liver of the specific cells of the liver, that is hepatocytes. So over there it forms schizoid and then it replicated again and again and it forms the merozoites. From the these merozoites, they are released from liver and it affect the human RBC. So it proliferate in human RBC and it destroys RBC and form hemolysis. Now within RBC there are male and female gametocytes. So with the second bite of female anopheles mosquito taken up the gametocyte and gametocytes fertilize within the mosquito, and that is the end of human cycle and that is the start of the female anopheles mosquito cycle. So these gametocytes fertilize within the female anopheles mosquito. These sporocytes form, and these sporocytes it again and again inject in the blood, and thus the cycle begin. So this is a bit short life cycle of Plasmodium, that it how it causes the RBC destruction in the form of hemolysis. Now let's discuss the some clinical features. Now, as we discussed earlier, there are different species of Plasmodium. So, what are those species? That is vivax, malaria, ovale, falciparum, and knowlessi. Now, the vivax and ovale, it is most common type. These are the most common type, most common species of Plasmodium, and these vivax and ovale, it cause the benign tertian malaria. It cause benign tertian malaria. Now, what does it mean? It means that there is fever spike every third day. There is fever spike every third day. But how? But why this such pattern is seen? The reason is during life cycle the Plasmodium merozytes it incorporated in the blood, and it formed the destruction of RBC, and it lead to hemolysis. And because of those hemolysis, there is the spike of fever is seen. So in case of vivax and ovale, there is benign tertian fever, but in case of malaria, there is quartan malaria. And quartan malaria means that there is fever spike every fourth day. So, and that is seen in Plasmodium malaria. While if we talk about Plasmodium falciparum, and Plasmodium falciparum, there is malignant tertian malaria. So there is malignant tertian malaria. So here the fever spike is irregular. There is irregular fever spike. So there is fever spike every third day. Here the fever spike is every third day, but it is associated with severe symptoms. So malignant tertian malaria, in malignant tertian malaria, the fever spike is every third day, but it is associated with severe symptoms. Quotidian malaria, it is seen in Plasmodium knowlessi, and here the fever spike is irregular. There is irregular fever spike. So these are all are the such pattern that is seen in different species of Plasmodium. But classically, these fever pattern it is not seen as so much commonly. So the such pattern of fever it is very rare. Now, what are the some symptoms of malaria? First of all, you should know what is the incubation period for malaria. The incubation period for malaria is 5 to 7 days. It means whenever person is infected with malaria, so up to 5 to 7 days there will be no symptoms, but after 7 days the symptoms begin to develop. From headache, there will be fever with chills. But remember, most commonly the fever which is seen in malaria, that is missense fever. Missense fever means that there is irregular pattern of fever. Diaphoresis, there will be diaphoresis, there may be nausea, vomiting, and there might be hepatosplenomegaly or jaundice, and that is because of damage of liver. And there might be thrombocytopenia, and severe cases there may be DICS, and hemolytic anemia lead to dizziness and weakness. Now let's discuss the investigations for malaria. So for malaria, there are two approaches. What is the best initial test? The best initial test and the best initial test for malaria, that is thick blood smear. Thick blood smear. But keep in mind, this thick blood smear, it will detect the presence of plasmodium. It doesn't detect the number of plasmodium, or it doesn't detect the plasmodium species. It only detects the presence or absence of plasmodium. It is negative. If this is negative initially, so then you have to repeat the test 3 times every 12 to 24 hours. While if you talk about the best confirmatory test, the best confirmatory test, so the best confirmatory test is, that is, yes, thin blood smear. The thin blood smear is the best confirmatory test, and thin blood smear, it will detect the species of Plasmodium. At the same time, it can detect the number of Plasmodium species as well. So the thick blood smear, it detects the presence of parasite, while thin blood smear, it tells the species of Plasmodium, and it detects the number of Plasmodium at the same time. We can do CBC as well, and the CBC, there might be thrombocytopenia picture, there may be hemolytic anemia, and there might be increased LDH. This increased LDH is because of hemolysis, and there is leukocytopenia picture. There will be leukocytopenic treatment. So in order to treat the malaria, we have two approaches, that is non-falciparum malaria, non-falciparum malaria, and falciparum malaria. Now, and non-falciparum malaria means that it might be Plasmodium vivax, ovale, knowlessi, and malaria. So in case of non-falciparum malaria, there the drug of choice is chloroquine. The drug of choice is chloroquine. And the dose for the chloroquine is, that is 620 mg, 310 mg, 310 mg, again 310 mg. It means that initially the 620 mg at the start, then 310 mg at 6 to 8 hour, then 310 mg at second day, again 310 mg at third day. Why we are giving chloroquine at this specific timing? Because we want to hit the life cycle of Plasmodium, so that Plasmodium is unable to replicate, right? So that's how we are giving it. Now we can also add primequine with this chloroquine. So we can add primequine, we can add primequine with chloroquine, and this primequine, it will destroy the hypnocytes of vivax and ovale in the liver, and the dose of primequine will be 30 mg daily for 2 weeks. If there is chloroquine resistant non-falciparum malaria, so in that condition we have to give the artemether, we have to give artemether, lumefantrine and lumefantrine. So in this condition we have to give artemether, lumefantrine. Also we can give atovaquone with proguanil and we can give quinine with doxycycline or tetracycline. So if there is chloroquine resistant non-falciparum malaria, so in that condition we have to give artemether lumefantrine, we can give etoquinone, proguanil and quinine plus doxycycline or tetracycline. Discuss the falciparum malaria. So there are two categories falciparum malaria, that is uncomplicated falciparum malaria and complicated falciparum malaria. Now in uncomplicated falciparum malaria we have different options that is artemether and lumefantrine, dihydroartemisinin, papiraquine, and we have a oral sulfate, quinine sulfate. So in uncomplicated falciparum malaria, the options is artemether lumefantrine, dihydroartemisinin, papiraquinone, and oral quinine sulfate. While if we talk about the complicated falciparum malaria means that now the falciparum they penetrate into the brain. So that is cerebral malaria. So in cerebral malaria, the patient having HB less than 8, right? The HB is less than 8, there might be acute kidney injury. Is the HB broken and it gets stuck in the kidney and it forms the hemoglobinuria. So there might be hypoglycemia, shock, and parasitemia that is more than 10%, and there might be DIC. What is the treatment option for the cerebral malaria? So for that we have a artesunate regimen and we have quinine regimen. But keep in mind the artesunate regimen, it is more effective as compared to quinine regimen, right? The side effect of artesunate regimen mainly that is delayed hemolysis. While if we talk about the side effects of quinine regimen, that is synchronism. Synchronism means the hearing loss and there is tinnitus. Prophylaxis of malaria. What does it mean? If someone is going to an area where malaria is endemic, so there is a highly risk of infection. So how in that condition we have to treat? So there are two approaches for prophylaxis. The one approach is the area where the non-falciparum is common. The area where non-falciparum malaria, where non-falciparum, the area where non-falciparum is endemic. So in that condition we have to give primaquine. Now if the area is endemic in falciparum malaria, so there is two options, that is chloroquine resistant and that may be chloroquine sensitive. So chloroquine sensitive and chloroquine resistant. And chloroquine sensitive, that we have to give chloroquine, that is the dose is 310 mg base per week, while 1 week before it should given 1 week before and 4 weeks after travel. while in another hand in chloroquine resistant we can give mefloquine and we can give doxycycline. So the dose of mefloquine is 250 mg per week, while 2 to 3 weeks should given prior, while 4 weeks it should given after. While in doxycycline the dose is 100 mg and it is given 1 to 2 days before, and 4 weeks it should given after.